You give me a minute. Just a second. I have to put it somewhere like regular.
So we are live.
Okay.
Can we proceed, sir?
I'm ready, but
Yeah, just a second. I don't know what's happening here. Yeah, okay, fine. I think, yeah, now it's okay. I'm also ready. We can start.
Yeah, so very good. Good evening, everyone. Good day, everyone, and welcome to our webinar on the role of TNFI in AS and JAK in RA. We have two esteemed speakers with us today, Dr. Shruti Bajaj from Mulchand Hospital, Delhi, and Dr. Bhakuni from Max Vaishali Hospital, Ghaziabad. They will be sharing their insights and experiences on the use of TNFI in AS and JAKI in RA, respectively. We believe that this webinar will be insightful and informative for all of you. Our goal is to equip you with the necessary knowledge and tools that you can use in your practice or personal life. We encourage you to participate actively in the discussion, share your thoughts, and ask questions. There is an excellent opportunity for us to learn from one another and engage in a meaningful conversation. So, without further delay, let's welcome our first doctor, Dr. Shruti Bajaj. Over to you, ma'am.
Yeah, thank you so much for inviting us to give this talk. And I hope this evening we can have a fruitful discussion. So I'll be speaking very briefly about the role of TNF alpha inhibitors in ankylosing spondylitis. So ankylosing spondylitis is not a very rare disease as we see as rheumatologists. So there are many patients that we see, and earlier it was a notion that there's no treatment. So you just keep on taking the painkillers and you just exercise, and that's how it was going. But during the recent times, during the last decade, last 10 years have been very revolutionary for rheumatology with the advent of the newer class of drugs, which are known as biological drugs. So TNF alpha inhibitors, basically what they do is to bring down the inflammation. They are the class of drugs which have a targeted action. So they block the inflammation and thus they do the reversal of the damage which is caused by all these inflammatory markers. Next slide. So ankylosing spondylitis is a chronic rheumatic disease which affects the axial skeleton, the peripheral joints, and the enthesitis. How is it recognized? It is characterized by the inflammatory back pain, symmetrical oligoarthritis of the lower limb. There's enthesitis, so where the tendon, it joins the bone, that thing is inflamed. So you may have like recurrent plantar fasciitis and these golfer's elbow, tennis elbow, and all these things. And specific organ involvement, like you can have uveitis, bowel disease, psoriasis, and lung-related fibrosis. Next slide. Okay, so the prevalence is 0.1% and 0.8%, and it's like the ratio is almost 9:1. So if 9 males are affected, then 1 female is affected. 80% of the patients who develop the first symptoms at an age younger than 30 years and less than 5 will have more than 40. So it's a disease of young patients. And the group is strongly and genetically, it is linked to HLA-B27 antigen. So that's the one we get tested every time when we see a patient with suspected inflammatory low back ache. Next slide. What are the features of angspon? So in brief, it has to be a sacroiliitis, that is the inflammation of the sacroiliac joints, the spinal inflammation, loss of the spinal mobility eventually. It mostly affects the axial joints, and then it is seronegative. Why is it seronegative? Because the rheumatoid factor is negative in this, and it is characterized by HLA-B27 positivity. Next slide. Okay, here you see, so there's a healthy spine and then the inflammation sets in and then you have a fused spine. So that basically limits your movement across the spine. Next slide. So what are the associated conditions? There are 4 main conditions. It's a spectrum. So you should ask for uveitis. The other thing is psoriasis and inflammatory bowel disease plus the lung fibrosis, which generally occur bilaterally in the upper zones. Next slide. It starts with enthesitis and then there is subsequent bone marrow involvement, which leads to osteocytes, and then there is synovitis. So all the 3 things are involved. Next slide. Okay, how will the patient present? So a young patient, young male walks into your office with the chronic low back pain, which is greater than 3 months, which classically improves with the movement or exercise and worsens with the rest or inactivity. There is nocturnal exacerbation of pain. So the patient will always say, oh God, I'm not able to sleep in the night. I'm restless. When they wake up in morning, the backache is worse. And then there's early morning stiffness, which is greater than 30 minutes. There is enthesial site inflammation. So heel, tender Achilles, patellar tendon, all of them are inflamed. Next slide. So how is it diagnosed? There's a modified New York criteria for the diagnosis, which has a low backache, limitation of lumbar spinal motion. There's a limitation of chest expansion, like you are unable to take deep breaths, and sacroiliitis along with that. Next slide. Okay, so how do we measure the disease activity? So it is measured on the functional level, and then on ESR, CRP, and the new ASAS criteria. So BASPI, BASDAI, and ASAS. Next slide. Okay, what are the medications which are used in ANSPON? So first and foremost were the NSAIDs, the non-steroidal anti-inflammatory drugs, which have been the sheet anchor drugs. Then we have DMARDs. Not all the DMARDs are effective or approved for this, but since there was no other drugs, we were using these steroids. Yes, they are given sometimes when there's a single joint involvement or there's too much of inflammation. And the other drugs are the biologic drugs, which we'll be discussing today. Next slide. So introduction of anti-TNF agents for the treatment of ankylosing spondylitis has been a landmark in the treatment of this disease. And let's go how this journey is about. Next slide. Okay, what it basically does, that we have to see that whenever an inflammation starts in the body, there are certain pathways. One is interleukin pathway, the other one is TNF generation pathway. So there can be interleukin blockers or there can be TNF blockers. Both these pathways are interlinked. So if you block one, the other is also affected and it also gets blocked. So here we'll be talking about the TNF alpha blockade. Next slide. So that's again, it shows what is the pathogenesis of joint destruction. There are various inflammatory cells. They come together and they lead to lot of destruction. So there are pro-inflammatory cytokines which are released, which bring up the inflammation and then subsequently destroy the joint. Next slide. Okay, so there are certain ASAS guidelines that which patients will qualify for the anti-TNF therapy. So there should be a definite AS. There has been an active disease for 4 weeks. BASDAI should be greater than 4 at 2 times, and the physician global assessment should be greater than 2 on a Likert scale. And all the treatment failure, all types of failures, whether they have taken no drug, some biological drug, the conventional DMARD or exercise or whatever, if they fail on the treatment, they qualify for the initiation of biologics. Next slide. Next slide, please. Yeah. Oh, this is a very, very difficult diagram, but what is the gist of it? It says that if you have a definitive patient, if you're made a diagnosis of ankylosing spondylitis, start the patient on NSAIDs, give them for 2 weeks in the maximum possible dose, 2 NSAIDs. If they fail, they qualify for the next level, which can be a DMARD or which can be a biological DMARD. Ideally, it should be a biological demand. Then you reassess the patient after some time, maybe 6 weeks, 4 weeks, and you see, yeah, there is improvement. Please continue the drug. If there's no improvement, you shift to another class of TNF alpha agents, or you shift to interleukin 17 inhibitors. Next slide. So that's the same thing that we've talked about. And so what are the anti-TNF agents? So there are many agents which are there in the market. What we basically have been using throughout our etanercept, infliximab and adalimumab. Next slide. Next slide, please. Okay, so what are the contraindications for the anti-TNF therapy? So if you are having a current or recurrent infection, it's just not a viral infection. It has to be a real big infection. Tuberculosis, multiple sclerosis, lupus, malignancy, and if you are pregnant or lactating, well, pregnancy is not a contraindication now because the TNF inhibitors, the adalimumab and etanercept, are approved for use in till third trimester. Next slide. How do we monitor? So there's a close monitoring of the patient regarding the side effects and the effects. So the BAS dye is done regularly, and we see that if there's a reduction of greater than 2, if the physician global assessment, the difference in the earlier starting, the initiating time, and this is greater than 1, then it is working. And now obviously the motility, the symptoms, the regular use of NSAIDs, all this comes down. Next slide. So let's talk about etanercept. It is approved in US and Europe for the treatment of AS, and definitely in India also. So the dose is 50 mg subcutaneous per week, which is given, or you can take 2 injections subcut for 25 mg each, maybe on the same day, or like giving a gap of 3 to 4 days. Infliximab, yes, it is approved. The initial dose for starting is 5 mg per kg, given at week 0, 2, and 6. And then 6 to 8 weeks thereafter, you have to decide the frequency at which you're going to give this drug. Next slide. Okay, so adalimumab, like Humira, by which it is known in the international market, is one of the most sought after drug. And recently I was reading that it did a business of $200 million because it is approved for a lot of indications, and it is a very safe drug to use. It also forms my personal favorite and immense experience with this drug. So adalimumab is a recombinant human IgG1 monoclonal antibody, which is specific for the human TNF. It is produced by recombinant DNA technology. And the mechanism of action is it binds to both the soluble and membranous TNF receptors. Unlike etanercept, it does not block lymphotoxin, and that's how it's basically a fully humanized TNF blocker. Next slide. Okay, what are the dosages? So TNF, this rheumatoid, adalimumab is used in rheumatoid, angstpon, and psoriatic arthritis with similar dosages. So 40 mg is administered every other week as a single dose. So every fortnightly it is given. Next slide. The efficacy of TNF inhibitors is super good, and they have shown the consistent improvement. The other thing that I must point out is that there's not much of a difference between the use of one TNF and the other one. There are no head-on trials much, and more or less their efficacy is same. It just depends on the cost effectiveness, what you can afford, because their intervals are different. So like golimumab is given once in a month, etanercept every week. So the patient can make a choice with that. It can be a patient-physician partnership to see what drug can be given. Next slide. Okay, that we have just talked about. Next slide. Again, the same thing. That's a pictorial representation that how after the use of these TNF inhibitors, it improves. The scoring and all improves. Next slide. What are the adverse events? Well, I've been using this drug for long, but I haven't encountered much of side effects with that. One patient I have seen of multiple sclerosis developing it afterwards, and we have seen few cases of tuberculosis, but then tuberculosis is anyhow very common in India, so you should just keep the patient in observation and monitor that. But overall, the drug is super safe, and it's a very, very nice drug in the armamentarium against ankylosing spondylitis. Next slide. Okay, fine. That's the same thing that we've been talking about, that it has shown a very, very consistent graph for improvement. Next slide. Okay, the same. We have the next slide. Okay, so that's the summary. So anti-TNF agents, they target the underlying inflammatory process. They alter the disease progression. They provide symptomatic reliefs, recommended treatment after trial of chronic daily NSAIDs, physical therapy and regular exercise. There should be a good safety and tolerability profiles. They implement treatment guidelines to ensure proper treatment given to the proper patients, and they should be under direct supervision of a rheumatologist, not just to see the improvement, just to catch the onset of side effects at the very early time. So that's the main important thing. Next slide. Thank you so much all for your patient hearing, and I'll be very, very happy to answer any queries. If you have, you can just put them in your mailbox and I'll be answering them.
I think Dr. Shruti has finished her talk. Probably it's my turn.
Okay.
If I may have the slides, please.
So you will be presenting, or I have to present?
Sorry, say again.
Do I have to present from my end, or you will be presenting your slide?
No, from your end. I don't have any wherewithal to start the slides. Please display the slide from your side. I'll say next. That's all.
Okay, so just a minute.
Sure. Good evening, everybody. The topic for today is JAK inhibitor, in particular tofacitinib. May I have the next slide, please? Well, if we see the spectrum of rheumatoid arthritis treatment, what I remember when I completed my training from SGPGI in 1998, the leflunomide and etanercept, that time they were introduced, and it was a big event in the treatment of rheumatoid arthritis. Sorry, excuse me. Then came 1999 when the wonder drug infliximab was introduced, and after that, adalimumab and other TNF inhibitors came. But what made the breakthrough in 2012 was JAK inhibitors, the oral biologics in the form of tablet tofacitinib. So since 2012, it is there at the helms of the affair for the treatment of rheumatoid arthritis. I clearly remember that when it was introduced earlier, the dose monthly, monthly, the cost of the treatment was 36,000 rupees per month. Gradually, after subsequently few years, it was 24,000 rupees per month. Then it came down to 18,000 rupees per month. And suddenly, for last 1 year, it is like 1,800 and less. The cost to the patient per month treatment. Next slide, please. Next slide, please. So how the JAK inhibitors are different than biologics? The simple answer is, next slide, please. Next slide, please. Next. Before that, previous one. Yeah, basically the JAK, the biologics, they bind the receptors in extracellular space, and then they act whatever the action is. Whereas the JAK inhibitors, they work intracellularly. Basically, they change the gene transcription. That's how the cytokine inflammatory production is stopped. So that is the difference. The JAK inhibitors, they work intracellularly, and the biologics, TNF inhibitors, they work in the extracellular milieu. Next slide, please. Next. So what are Janus kinases? Basically, they are the family of tyrosine kinase. What they do? Next slide, please. The tyrosine kinases, basically, they activate the signal transducer and activator of transcription. And these signals are produced inside the nucleus, and various cytokines which are inflammatory in nature, they are produced. So what the JAK inhibitors, they do, they block these stats, the JAK inhibitors, so that the production of pro-inflammatory cytokines are stopped. So that is the advantage. Next slide, please. So that is what same, the JAK stat signaling, as I told you, that basically there is a transcription is changed, and the production of inflammatory cytokines are stopped. Next slide, please. Next, please. Next, please. So same path. Whatever I've told you in 1 or 2 lines, it is being shown in different formats. Next slide, please. Next. So basically, they are JAK1, JAK2, JAK3. JAK family is large family. But what we are concerned today is basically only on tofacitinib. Next slide, please. Next slide. So tofacitinib was the first drug approved as the oral biologics. Basically, this is the drug which binds to JAK1, JAK2, JAK3 family of tyrosine kinases, and it was approved in 2012, as I told you, by FDA. And after that, in 2016, it was also approved for psoriatic arthropathy. In 2017, it was approved for the treatment of ulcerative colitis. And in December 2021, it was approved by FDA for the management of ankylosing spondylitis. However, the Indian DCGI approved is only for the treatment of rheumatoid arthritis and psoriatic arthritis, what I know of. Next slide, please. Next. So tofacitinib, the mode of action is basically, this is a JAK inhibitor. This is a repeat of whatever I have told you earlier. And there is a prevention of STAT activation, which blocks the signaling inside the cell, and the resulting in inhibition of the further production of cytokines and inflammation. Next slide, please. Next. Indication, as I told you, various indications. Amongst them are the four main indications are treatment of rheumatoid arthritis, psoriatic arthropathy, ankylosing spondylitis, and ulcerative colitis. In the difference is that in psoriatic, in rheumatoid arthritis and ankylosing spondylitis, the dose of tofacitinib is 5 milligram twice a day, whereas in ulcerative colitis is double the dose. Next slide, please. Dosing, as I told you, it is 5 milligram twice in a day in adult. Next slide, please. The efficacy of tofacitinib in rheumatoid arthritis is well established now. Next slide, please. Next. Next. These are old slides, so I mean, there's no trial now. This, tofacitinib is a well established safety. Next slide, please. Next. The toxicity is basically what we are worried about, basically the pancytopenias. We ask the patient to have 4 weekly CBC, means hemoglobin, total leukocyte count, as well as platelet counts. The other side effects, we keep a watch on the transaminases, basically SGPT or ALT, and serum creatinine. Beside that, the commonest, next slide please. The other side effects we take care of is appearance of rashes in the form of herpes zoster rashes. And in the individuals who are more than 50 years of age, we also take care of any episode of rapidity of breath or dyspnea, sudden onset dyspnea, and we look forward for any thromboembolism episode. And in other biologics, we also screen the patient for any latent tuberculosis or latent hepatitis B and C infection. Next slide, please. So as I told you, the other uncommon, previous one, please. The other uncommon side effects which we hardly see. Previous one slide, please. Previous slide. Yeah, the GI perforation and rest of the things I think I already told, except GI perforation, DVT, and increased lipids. Next slide, please. Next. Serious infections, biologic versus tofacitinib, almost same. There are hardly any difference. Next. So the key highlight of tofacitinib is that it is the first orally approved JAK inhibitors in the world. It has a unique mechanism of action by inhibiting the STATs or the transcription of the pro-inflammatory cytokines inside the nucleus, and rapid onset of action. In fact, the patient of rheumatoid arthritis and ankylosing spondylitis or spondyloarthropathy, they get relief within 5 to 7 days. And there's a proven efficacy and safety, and it has been noted that the sustained efficacy of this drug, tofacitinib, stays for 8 years, and long-term safety has been measured up to 9.5 years or so. Next slide, please. So basically, it has a place in therapy. Guidelines recommendation in EULAR 2019. After that, EULAR recommendation in 2022 has also come, which says that in the phase 1, we have to give methotrexate and combination of other drugs like hydroxychloroquine. If the patient is not, intolerant to methotrexate, we can start with sulfasalazine or leflunomide. Tofacitinib is, recommended in phase 2. In EULAR 2022 recommendation, as well as in ACR recommendation also. Phase 2 meaning thereby, if the patient is not improving with methotrexate or in combination of hydroxychloroquine, sulfasalazine or leflunomide, then we add for 3 months or so minimum, then we add tofacitinib. And tofacitinib has the role also in stage phase 3 also. If we have not given patient tofacitinib, if we have treated the patient with only TNF inhibitors. So tofacitinib has a role in basically phase 2 and phase 3 of rheumatoid arthritis, whereas in ankylosing spondylitis, we straight away start the patient either on TNF inhibitors or on tofacitinib. There is no phase 1, phase 2, and the results are very, very good. Of course, we have to look forward for any side effects, and the commonest side effect which I have seen in my practice is herpes zoster. And if we screen the patient properly for tuberculosis and hepatitis B and hepatitis C, these kind of infections are also not seen. But one word of caution: any patient, if you are putting that patient on tofacitinib, if he is of beyond 50 years of age, please look forward for DVT or thromboembolic phenomena. Next slide, please. So that I've already, all the guidelines I've already told, although this slide belongs to 2019, but I've told you the recommendation in EULAR 2022. Next slide, please. Next. So in summary, is a good drug. Indication, as I told you, in rheumatoid arthritis in phase 2 and phase 3, in ankylosing spondylitis, right from the beginning we can start after the proper screening. Side effects, look forward for pancytopenias, look forward for transaminases increase, look forward for any increase in serum creatinine or lipid profile. GI perforation is a very rare one. Commoner is herpes zoster, and if the individual is more than 50 years of age, look forward for any DVT or thromboembolic phenomena. And the best part is the oral administration. And I'll not say the last part is very good, that the cost to the patient is very less. Nowadays, it is available from 900 rupees till 2000, 1800 rupees or so, depending on different companies. Thank you very much. I finish here. Last slide, please. Yeah, thank you. Any questions from anyone? You're most welcome to ask. I think this question is for Shruti.
Yeah. So there are no recommendations for, any food change or lifestyle changes in lowering TNF levels. But if you can stay away from smoking and alcohol, because smoking is a known factor for aggravation of ankylosing spondylitis. So probably if you don't smoke, so that's gonna lower your TNF levels. Rest, you can eat anything, and lifestyle changes is like regular exercise is recommended. It should not be a vigorous one, but then it is recommended. Okay. What are the various predictors of response to TNF inhibitors in patients with ankylosing spondylitis? You can do a periodic visit. You can see that how the patient is, telling. There are various scorings that I had discussed, that you can do a BASDAI score. Then CRP is also another one marker that we do very regularly to see for the response. This is for Bhakuni sir. What are the indications for? Yeah.
What are the indications for JAK inhibitors initially in RA? Well, if the patient has come to us in a severe condition, in the sense that he's almost, the rapidly progressive rheumatoid arthritis, and the patient cannot afford other biologics, and we know that methotrexate will take some time to act, hydroxychloroquine will take months to act, and painkillers we cannot give to the patient. So the best policy to start tofacitinib or JAK inhibitors immediately. We can start it in phase 1 also, depending on the severity of the patients. Patient's condition of rheumatoid arthritis. Otherwise, start with methotrexate. Most of the patients, they improve. Next question is, how early is reduction in radiographic progression observed in RA patients taking JAK inhibitors? Well, it depends from 6 months to 2 years, depending on patient's condition. We cannot predict that the radiological changes will come so soon, but the clinical condition of the patient improves dramatically. What are the clinical conditions? Basically 2 or 3. The pain is this almost disappears. The swelling comes down, and the early morning stiffness is within less than 5 minutes or so, if the patient responds to TNF inhibitors. But the radiological progression, the changes come only after 6 months, and till 2 years, they can communicate. how would you rate the safety of profile of various JAK inhibitors when used for? Well, we have in India we have used only two, baricitinib and tofacitinib. Basically, both are same. I have not found any difference in the toxicities of baricitinib and tofacitinib. But they say that baricitinib herpes zoster may come more frequently in more patients. But I haven't seen that, so I don't have any hands-on experience of differentiating the toxicities between baricitinib and tofacitinib. Which JAK inhibitor is the most effective? Basically, in refractive RA, odacitinib, how do you pronounce it? That is not available in India. I think that is being used in USA. They don't use tofacitinib usually. They use the third generation tofacitinib. Do JAK inhibitor work well in patients who have not responded? Of course, yes. If the patient has not responded to DMARDs, we have to, use tofacitinib and JAK inhibitors. They work wonderfully well. I have yet to see a patient who has not, shown any improvement after JAK inhibitors. Well, we are just scared of the toxicity, which are not very much also, but we have to be in guard. But the patient, they respond very well.
So we are done with the questions.
Okay. So, we have done with the patient, questions. Take care, Shruti. Thank you very much. I think it was a great, this thing. You spoke very well. And my topic was almost in the practical points or tips or whatever thing I told. I didn't go through the rigmarole of those, slides, because basic aim was to whosoever our viewers are, to tell them the practical tips. Look, that this drug is very important. Is it cheaper? Is orally administered, and we can monitor the drug very safely, and its effects, the results are very good.
Ji sir.
Chaliyo. All the best, Shruti. Bye bye.
Sir.
Thank
Okay.
you.
Thank you so much, sir. Thank you so much, ma'am, for your valuable insights. It was a great session, and we look forward for you in future. Thank you.
Okay, thank you, man. Thank you. Bye bye.